guys. Hi, Esther. Hi, Esther. I'm main campus. I'm Esther Kawamura. I'm an instructor here at Kenyatta. Let's see, my background, 2 years med-surg, 15 years ICU, was a manager of ICU. Then I was a quality and risk manager, and then I did some public health, and then I went into education. Wanted to get back to my med-surg roots, so I became an educator for the medical surgical unit and for the emergency department. So I've got different types of experiences. I love ICU, but I really also love med-surg because that's really where I get to talk to people and I really get to assess them without the use of monitors. But I'm going to talk about ICU today, okay? Since that's what we're going through. Okay, so concerns of the critically ill patient. Wen gave me a nice laundry list of things to talk about, so I'm going to try and get to it as much as I can. So basically, this is what I picked. These are mainly the common concerns of ICU. Nutrition. Nutrition is a concern for any patient, not only in the ICU, but any patient in the hospital, pediatric, adults, anybody. Sleep, anxiety, pain, delirium, mobility, and family. And if you're in the ICU, and some of you are, and you see all those lines and tubes, can you imagine trying to get any sleep, any food, anything done, any healing done in the ICU? So let's just talk about them one by one. Let's start with nutrition. Okay, the problem with nutrition, and this is basically for anybody, is that many patients, once they're hospitalized, they're unable to tolerate their normal diet. The other thing that happens is because they're sick, they've got a lot of physical demands on them, and so they need more nutrition, particularly more protein. But also, a lot of patients come into the hospital, and they're not really, not just hydrated, but they're almost sometimes malnourished. And this happens a lot in the elderly. You know, the elderly come in, and a lot of them are really not nourished well, and then we're trying to heal them with what body reserves they have. So that's the top part about anyone coming into the hospital. In the ICU, I think the biggest challenge is that we don't start patients early enough on nutrition, and that once we start them on nutrition, they get interrupted a lot. Okay. So critical illness, I don't know if your slide has this, but I might have changed the slide, because you know I do that all the time, I change it up, didn't I? So critical illness plus poor nutrition equals, and this is what happens when we don't have good nutrition: increased morbidity and mortality, prolonged length of stay, impaired tissue function and wound healing. Okay, calories. We need calories to heal our wounds. We need protein to heal our wounds. We need about 30 to 35 kilocalories per kilogram for adequate wound healing. Okay. We have overgrowth of bacteria in the GI tract when we're malnourished. Okay. Can you imagine not eating for a couple of days and what your stomach feels like? Think of all that acid in your stomach. Okay. And think of all that bacteria that's just sort of collecting in your gut. And then, of course, impaired immune system leading to increased risk of infection. Okay. So, when do we start nutrition? Ideally, what we need to do is we need to start it 24 to 72 hours on admission. On average, in the ICU nationwide, the patients get started on nutrition in about 48 hours. So we're kind of missing the mark there. We're kind of in that ballpark, but we're missing the mark. We really need to start nutrition right away. And enteral feeding is a method of choice because it's more physiological, okay? But if we can't do enteral feeding, then we do TPN, okay? Everybody has been on the floors already. We all know what TPN looks like. We call them banana bags because they're nice big yellow bags, and they're yellow because of the vitamins. But in the ICU, it's great to start enteral nutrition early, but then we've got some challenges. And One of them is aspiration. And actually, this is not just in the ICU. This is on the floor. Anybody who has enteral nutrition, this is the big complication, and that's aspiration. And aspiration leads to pneumonia. I talked to you guys about some of the horror stories of tube feedings that did not get turned off when the patient's head of bed went down, right? And then through the NG, it's going through the stomach, and then patient coughs, and then we have aspiration pneumonia. But in the ICU, a lot of times we have aspiration related to altered mental status. Sometimes we just put in the ET tube. Sometimes after we just intubate someone, and maybe we're suctioning, and we forget to turn off the tube feeding, and the patient starts coughing and coughing because we're suctioning them through the ET tube. Sometimes that's how patients get aspiration pneumonia. Also, high gastric residual. Remember when we did insertion of NG tubes, right? And before we, if it's a continuous, what we have to do is every like 4 hours, whatever the doctor says, we need to check for residual, meaning we have to aspirate back, right, to see how much has been absorbed. Sometimes if the patient's not absorbing, we can either hold the feedings, or sometimes we can give them probiotic type drugs to absorb the feedings more. But high gastric residual diarrhea is very common in tube feedings, and abdominal distension and complications, and then of course interruption in feedings. I would say that the GI complications account for about 50% of the reasons why we hold feedings or some of the complications of feedings. Okay. I put this magazine cover up because I'm just plugging, and this is my plug. So when you guys become nurses, you all need to subscribe to something, some kind of journal. Okay, that's the only way you're going to keep up with practice. And so this came up, I think this is last year, and I put it up because one of my good friends actually did the research on this. But she did the research on interruptions in enteral feeding, and that's a really big problem, because what happens in the ICU is the patient's getting tube feeding, but then we have to interrupt it because we're suctioning, or we have to interrupt it because we have to put the head of the bed down because we're doing care, or we have to interrupt them, we have to turn it off because we have to do a procedure, or the patient's going for a CAT scan, and we have to transport them. So on average, the patient doesn't really get feedings for about 5 hours a day, and that's all due to interruptions. Okay. I would say that procedures account for about 50% of the interruptions. The other 29% has to do with clogged feeding tubes. Okay, 29% of the time we're interrupting feedings for several hours because the feeding tube is clogged, and now we have to put in a new one. That's why it's really important to always flush your tubing so that they don't get clogged. Okay. Strategies to minimize interruptions: keep the head of the bed up. Check gastric residual volume. Every institution has a hold for residual volume rule. Some of them are 250, some of them are 500, so you need whatever facility you're in, and if your patient's getting tube feeding, you need to check the orders to see when you're going to hold the feedings for residuals. Prokinetic agents, you need to consider that if you have a problem with gastric residual. Reglan is a really good prokinetic agent. It's also used for GERD. And we used to use erythromycin, but we're not using that anymore because of the risk of using too much antibiotics. Resistant, you know what I mean, resistant antibiotics. Okay, so if we can't use enteral feeding, we want to do that, right? If we can't use it, then we have to use parenteral. The reasons for this that we use parenteral are usually because the GI tract is not functional, and a lot of times it's because of paralytic ileus. What's paralytic ileus? Is it really paralyzed? Peristalsis doesn't work, right. It's not an is it an obstruction?
No.
No, it's not an obstruction. Okay, so it's basically the bowel's not working. Peristalsis is not working. Okay? It's not a structural, it's actually a pseudo obstruction is what it is. And it's actually very, very common in infants. Who's peds? Common, very common in infants. So it's paralytic ileus, or you can't access the GI tract, or because of inadequate GI feeding. So I think I remember talking about TPN last semester. The only thing I want to tell you is just be careful. This is an expensive way to feed people. You have to watch for CLABSI, which it's a bundle, so what is that? What's CLABSI? People. Central line associated bloodstream infection, right. Okay, that's the first bundle we're talking about. And of course it requires venous access, right? So that's why you're gonna you might have CLABSI. Remember, when you're changing a central line, you need to wear a mask, okay? Always wear a mask and gloves when you change central lines to prevent CLABSIs. So, summary. Start early, about 24 hours, okay? Use the gut if you can. You want to monitor lab values, but don't exclusively rely on them. What lab value are you going to look at to determine whether a patient is nutritionally sound?
BUN?
You can, right? BUN.
Albumin.
Albumin. Albumin is very common. Okay, a lot of BUN is also correct, but a lot of times we're looking at albumin as a marker for nutritional status. Albumin, though, has a half-life of about 14 to 20 days. So it's a good marker if you're looking for chronic nutritional status. What you want to look for acute short-term nutritional status is pre-albumin, because pre-albumin has a shorter half-life. It's about 2 to 3 days. Okay? So it changes more with nutritional intake. Now, the reason why I say don't exclusively rely on labs is that albumin and pre-albumin can go down in the presence of inflammation. Okay. So, if you have inflammation, so sometimes you don't know if the albumin and pre-albumin is low because of nutrition or is it because of inflammation. So to check that, sometimes we order C-reactive protein. So we'll order C-reactive protein and pre-albumin to see what C-reactive protein actually is a marker for inflammation. Okay, so that's how we can tell if it's actually a result of inflammation or nutrition. So those are 2 lab values that's kind of nice to know. Sleep problems. Do we all look like this before a final? Do we look like this every day? Every day. Do we look like this after Dr. Lee's class? Oh, no one's going to admit it.
After farm lecture.
Okay, after the farm lecture. No, the farm lecture you guys are going to love.
Yeah.
Seriously. Okay, so the total number of hours of sleep over a 24-hour period may be normal, like 7 to 9, but about 50% of the sleep hours occur in short bouts. And it's difficult to achieve delta, which is non-REM, and REM sleep. Okay, so can you imagine trying to sleep, but just for like taking a whole bunch of little cat naps? Are you going to feel refreshed? No. Okay, because you need that delta sleep. So let me tell you what delta sleep is. Let's go through the stages of sleep. So stage 1 is when your eyes are closed and you can easily be aroused. Stage 2 is light sleep and your heart rate goes down a little bit and your temperature drops. Stage 3 is the delta sleep, and that's where your body is healing in stage 3. Okay, your tissues are healing, your bones are rebuilding, your immune system's revving itself up. So this, at stage 3 in delta sleep, this is the sleep where if somebody tried to wake you up and you woke up, you'd be a little bit disoriented. Have you ever been in a hotel room and then you wake up and you look around and you think to yourself, well, where am I? Right? It's like, I don't know where I am. Okay, that's a delta sleep. That's where you're doing your deepest sleep. That's where you're really doing a lot of your dreaming. And also, you're also doing a lot of dreaming in your REM sleep. Your intense dreams are in your REM sleep. Actually, in stage 2, when, just when you're starting to come down, when you're starting to sleep, that's when you have those myoclonic jerks. You know how people sleep and they go like this? Right? Okay, that's stage 2. And then, of course, in your stage 3 is your deep sleep, and your stage 4 is your REM sleep. And you go through those cycles, but you don't start. You start off obviously at 1, but you go through stage 1, 2, 3, 4. Then you go back up to 2, 3, 4, and it's just kind of like back and forth. You're not in deep sleep all night long, obviously, because you got to wake up, right? So, but in REM sleep, that's actually when your brain is the most active. That's when your brain is, it's actually, if you look at the EEG, that's when your brain is really active, but your muscles are just totally relaxed. It's like you're paralyzed. That's what the 4th stage of REM is. So, sleep problems in the critically ill, and this is, again, not just for critical care patients, but actually for any hospitalized patient. What contributes to sleep disorders, sleeping problems, pre-existing sleep disorders? What do you think would be a good pre-existing sleep disorder?
Sleep apnea.
Sleep apnea, yes. What else? Have you guys heard of restless leg syndrome?
Oh, yeah.
Yes. We're hearing that a lot, right, on the radio and TV.
Yeah.
Restless leg syndrome actually just only happens at night. And that's when people, they just feel their leg hurts. And they just wake up and their leg hurts, and nobody knows how that happens. But people with Parkinson's tend to get restless leg syndrome, so you treat it with like dopaminergic that you use for Parkinson's. But restless leg syndrome is another one, and then of course the other one is circadian rhythm disorders, and a lot of elderly people have that, where they go to bed, grandma and grandpa, they go to bed like at 7 o'clock in the evening, right? And they wake up at 3 in the morning.
Yeah.
And even if they go to bed late, they still wake up at 3 in the morning. Yes.
I read, I think a year or 2 ago, that the pineal gland secretes less melatonin as we age, and that was one of the precursors of what and that's why the supplements. So is that something that you consider, or that
Melatonin?
Yeah, as not necessarily in the ICU, but
Yes. Yeah.
okay.
Yeah.
Menopausal women.
Menopausal women. Yeah. It's just one of those, sucky things that happens when you start when you age.
I'm aged. Would you just call it?
Circadian rhythm disorder.
Oh, yeah, that's what I thought.
So circadian rhythm disorder in a normal person, okay, when you work shifts and you just people who are going to work night shifts, you're going to have some of those circadian rhythm disorders where you can't decide when you're tired and when you're awake, and good luck. I worked night shift for 2 years, and the only thing I remember about it is I always counted the number of hours I slept. If I got 4 hours straight, I was happy.
Wow.
And I just, that's all I wanted was 4 hours of straight sleep.
So I have a question, because you're talking about the circadian rhythm and switching your schedule and stuff. The best way to conquer that is like sleep medication to get you back on a cycle? Like, what do you do for these elderly people?
Okay, sleep medication, doesn't work for everybody because medications, like any medications, interferes with the sleep pathways, okay? Have you, sometimes people take medications and they wake to sleep and they get their 8 hours of sleep, but they wake up and they feel like crap. They're just tired.
Yeah.
So it's not necessarily the best thing, but if you have a problem with sleeping, then yeah, if you need to sleep, you need to sleep. If not, you'll get delirious, right? So anyway, okay, and sleep contributes to delirium, there you have it. So pre-existing disorders, underlying illnesses, anxiety. If you're in the ICU, you're anxious, and if you're anxious, you can't sleep. If you have a test in the morning, if you have a checkoff, right, you're anxious and you can't sleep, right? Okay, if you're in pain, you can't sleep. If there's frequent monitoring, the nurse is always going to wake you up every 2 hours. You can't sleep, okay? The ICU environment is, just conducive to sleeplessness. So strategies to promote sleep, really, the first thing you want to do is control your environment. You want to have the patients sleep. I think in our ICU, we don't allow visitors at a certain period in the afternoon. We allow them to sleep. Check that for me. I think there's an afternoon period where we actually don't let people sleep, visitors come in, right?
Yes, from 2 to 4.
From 2 to 4, thank you. Right. We dim the lights at night. We turn the lights on at day. Right? Open the curtains during the day. We limit the noise. The noise is incredible in the ICU. Maybe not so much on nights, but on days it's just like crazy noisy with all the alarms. And then we plan our treatments accordingly. Pharmacological considerations, sedatives are good, right? But if we want to use sedatives, we want to use short-acting ones. But again, sedatives exert their effect at different points in the nervous system along the sleep pathway. Okay, so we need to be careful with that. Analgesics are good if we're in pain, but remember, we have to be careful. If we're going to give sedatives and analgesics, we have to be careful when titrating to prevent symptoms of withdrawal. Okay, so summary. We want to try to have people sleep naturally. Before we sedate, we want to control the barriers to sleep, which is all those things you see. And remember that sedative use is both a potential treatment and a cause for sleep disruption. All right, pain. We're just like clean through this here. Okay, more than 30% of patients, ICU patients, have significant pain at rest. Imagine it's just laying there and just not moving yet, still being in pain. I mean, how many of you have migraines? Okay, and you're just laying there and it's unrelenting, right? You're just in pain. And there's nothing you can do. Nothing you can do, right? Right. So these guys have pain. 50% have significant pain during routine care, meaning if I'm going to give you a bath, you're going to have significant pain. Okay. Now, the expected practice for assessing pain, the gold standard is patient self-report, obviously. We want to use that 0 to 10 pain scale. We also use what's called the behavioral pain scale or the critical care, the CPOT, critical care observation tool. But you need to remember that behavior scales, that's basically observing people's behavior, it's good in detecting moderate to severe pain. So if I'm doing this, you know that I'm in severe pain. But mild pain, you wouldn't be able to tell if I'm in mild pain because I'm not clenching and I'm not doing this. So behavior pain scales are good for I would say moderate to severe pain, but not very good for mild pain. Also, avoid relying exclusively on vital signs for pain, okay? And I know we talk about how your blood pressure goes up and your heart rate goes up when you're in pain, but when you're in the ICU, there's so many other things that are going to make your pressure and your heart rate go up, so you can't exclusively rely on vital signs. And then, of course, you could, if someone's intubated, you could ask the family to kind of interpret the behavior. But the research shows that family always overestimate their family members' pain.
Yeah.
Because, they want their family members to be comfortable. But, if that's the only thing you can do, that's the only thing you can do. So this is the CPOT, the Critical Care Observation Tool. So that's an example of that. And for infants, you're going to use FLAC, the faces, limbs, arms, crying, consoling tool. That's for infants. And then for children, use Wong-Baker Happy Face Scale. Okay. Alrighty, so how to treat pain. IV opioids is the first line of drug for non-neuropathic pain. So that's basically any pain except neuropathic pain. But for neuropathic pain, you're going to use gabapentin, which is Neurontin, or I don't know, I never say that right, but it's Tegretol. It's Tegretol. I look at it and I don't say the word, I just say Tegretol because I know what that is. And both of those are actually anticonvulsants, okay? But they're really good for neuropathic pain. So Neurontin is good for shingles pain, okay? And Tegretol is good for trigeminal neuralgia, that facial pain, tic del roux. That, yes? No, not ringing a bell. Facial nerve pain, where if you just touch someone's face, they'll be in severe pain. It's called tic de la roux.
Tic de la roux?
Tic de la roux. That's my phone.
That's a nice
Okay, next. Yeah, that's kind of like a sedation sound.
I was gonna say.
Okay, so speaking of sedation, wow. Okay, so why do we sedate in the ICU? Why do we sedate? Because we've got a patient who's in pain, who's fearful, who's anxious, who wants to sleep, who's got all this excess stimulation. They're intubated, they can't communicate. That's why we sedate people. And we have to sedate them, because they won't get any rest if we don't. So, how do we measure sedation? We're going to use the RASS scale. Sedation is measured and monitored using the Richmond Agitation and Sedation Scale. Those of you in ICU, be familiar with this. You're going to use this every shift. Every shift, you monitor for this. Okay? And basically, it is a scale, and I put two of them up just so you can see, happy face and words. A RASS score of 0 means you're just alert and oriented. And then as you increase your agitation, you go up like to 4. And then as you decrease agitation, become more unconscious, you go down to the negative. Who's in ICU? ICU, 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 ICU. Have you, any of you started yet?
Gina.
Have you seen the RASS scale?
Yeah.
Have you used it?
Yeah, she's just drowsy because it's nighttime.
Okay, yeah. So every shift, right, you're having to use the RASS scale.
I think like every 4 hours.
Every 4 hours? Okay. So treatment of sedation, usually non-benzodiazepines, but we can also use propofol, and propofol is used a lot in the ICU. It is an anesthetic, hypnotic. It is very rapid, short duration, so that's what we use. Precedex we also use. I don't think as much, actually some hospitals use Precedex a lot. And then there's the benzodiazepines, which is the diazepam, lorazepam, and the dazolam. Okay, you guys need to know those 3 drugs, I'm just saying, because you're going to use them all. And who knows, it might be on your boards. But these are very, very common drugs, and everyone's going to probably be exposed to these drugs. So, what else did I wanna say?
The three benzos or the three, or
The 3 benzos.
three benzos?
Yeah, yeah. Don't you think we use a lot of that Valium, Ativan,
Oh, yeah.
or
In
setting?
every setting.
In every
Even on
setting,
MS.
in every setting.
Yeah.
Have you guys heard of Haldol? Okay, Haldol is, you can use Haldol, but sometimes it's got this rebound effect. You know, sometimes you give Haldol and the patients get even more agitated. Okay, so it's not necessarily the best.
The differences between those benzos?
You mean what they're used for, huh?
Why would they give one benzo over another one?
Okay, well, Valium, you guys know, that's sedation. It makes you calm and relax. Ativan is if somebody's anxious. Ativan is used like with an alcoholic a lot of times to make them calm, more calm. It's more like anxiety type. And Versed is used actually for sedation.
Yeah.
We use that because it's a quick, you give it when you're doing a procedure on a patient,
Endoscopies.
like endoscopy or whatever, because it's quick and it comes off quick, you
So
know.
why Valium versus Versed versus Valium?
Valium basically, it's calming agent.
And it's longer acting
It's
too,
longer
it doesn't,
acting.
Versed is for procedures primarily, you know, like if you have a dislocated shoulder, you're gonna give it, because it works quick, knocks the patient out, and then it wears off.
So the
You know.
difference is Versed is the only one that kind of knocks them out a little
Pretty,
bit. The
it
other two.
knocks out pretty well.
Okay,
Yeah.
and the other two, it doesn't have
Yeah.
knockout agent,
No.
it's just calming.
Yeah.
Ativan
is
will kind of knock you out a little bit,
Okay.
But
but
it's-
not as much.
Yeah, it's a lot for
Versed.
anxiety.
So
For the alcoholic that
yeah,
is
so
shaky.
patients who are withdrawing from alcohol, and we'll put an Ativan drip, and we'll put them in the ICU. Jonathan.
Over at the VA in the psych unit, they use what it's called the cocktail. They use Haldol, Ativan, and Benadryl mixed together for patients that are being combative and like that are restrained, 4-point restraint.
Wow.
But the question is that you said Haldol makes you a little agitated, and Ativan.
Sometimes it does.
So doesn't it have a counter effect of Ativan because that's supposed to like if you're agitated, it calms you down, and then Haldol actually agitates you, so
No,
it doesn't. have-
Haldol is supposed to calm you down,
Right.
but in some patients, it has an opposite effect.
I think you would probably know right away if it had an opposite effect, because your drugs wouldn't work on your patient.
Yeah.
So you'd say, okay, this cocktail isn't working, I need a martini instead, you know, I mean, you just realize that.
Right.
But I'm sure it doesn't happen that often,
Okay.
is what she's saying.
Yeah.
It's just one of those
It's just things you gotta,
complications.
you gotta kind of put it.
You gotta watch your patient and see what's happening.
Yeah.
Because in a normal world, your cocktail probably works really
Yeah,
well on these
yeah.
patients.
Yeah, exactly.
I've seen
Yeah.
Haldol.
Because you gotta protect your staff
Yeah.
too. You gotta
Yeah.
protect the patient and you guys, so you have to give them something, which sounds terrible, but it's better than 4 points.
I've seen those counter effects of Haldol in the very elderly. You know, we think we're gonna calm them down by giving them Haldol, and then all of a sudden they go, ah, and they're screaming and screaming. And then you think to yourself, well, I just gave her Haldol, and then, well, maybe that's what, but not often, but just so you know.
The
I've also seen it with Ativan as well in elderly. I've also seen it with Ativan.
You've
where
seen
they
that with
actually do the
Ativan?
opposite, like they get
Yeah.
more anxious and
Yeah.
almost
Yeah,
delirious.
so you gotta be careful with benzos.
Yeah, and elderly. I think they react totally different than the normal
Yeah.
person.
Does Valium last a lot longer than Ativan, or do they both have a?
Yes, I think, well,
I don't know the number. of
I
benzos.
don't know, actually.
You're gonna get a farm lecture next week, so that's what.
That you can ask her.
Yes.
Oh, is she coming next week?
She's coming
Yeah.
next week.
Oh,
And
did
then the
you meet
following
her?
week,
Oh,
2
you
weeks,
love her.
yeah.
Yeah, okay. Okay, so speaking of like going crazy, delirium.
Can they be addictive if you take like benzos?
Oh, God, can they be addictive, you know?
What?
Can
Yes.
benzos be
Yes,
addictive?
right.
I think any drug can be addictive, yeah. But I don't know.
Yes.
I guess,
Yes.
yeah.
I had a friend who
But it's
was
not
addicted.
Really? Yes.
I had a psych rotation last semester, and they're highly, highly addictive. So you have to be really careful with them. And I forget the other option for treating anxiety. That's not a benzodiazepine, but it's recommended if you can do that. picked to do that instead.
Yeah.
Yeah.
Do you remember it? No.
No, I wish,
Okay.
but
Well, I guess what you're saying though, if it's an acute situation where you have to, if you're just gonna do it, like in an ER setting or something, then you do the Ativan. But if it's long-term, you
Yeah.
wanna be aware that you don't, the patient doesn't get hooked on it.
exactly,
So,
yeah.
I wish I knew which, the other one.
I can email you guys if you want.
Or you ask the pharmacist next week.
Oh, yeah.
Oh,
There
there
you
you
go.
go. Oh,
Okay.
because they're gonna be taped. Are you taping for them?
Yeah.
next week?
Okay.
Yeah.
I have popcorn in here.
Delirium. So it affects 60 to 80% of mechanically ventilated patients. And generates 4 to 16 billion in cost. It is associated with increased length of stay, ventilator time, mortality, and long-term neuropsychological deficit. Some people actually have, once they get home from the ICU, they actually have some PTSD type symptoms. Okay, and if it's undetected, and it is undetected and untreated in a lot of patients. So really, it's good to treat the delirium early. Okay, so this is delirium, what delirium is. There's 3 types. There's a hyperactive delirium, and that's where their patients are really agitated, and they're trying to pull out their tubes and their catheters, and they're very emotionally labile. Then there's hypoactive, where you've got someone who's just really flat and withdrawn and semi-unresponsive, and then you've got the mixed. For the most part, in the ICU, you're going to see mostly the mixed type of delirium. You would think that it would be mostly the hyperactive, but it's actually more of the mixed that you see. So, assessment of delirium. This is called CAM-ICU, Confusion Assessment Method. In the ICU, along with RASP, the Richmond Agitation Sedation Score, you are also doing the CAM-ICU. Yes?
Yes.
Yes. Okay. In conjunction. Okay. So this is basically a method to determine whether your patient is delirious or not. And to determine whether you're delirious, you need to have feature 1 and 2, and either 3 or 4. Okay. So, level of consciousness. When we're assessing level of consciousness, we are assessing arousability, and that's where the RASP part comes in, and content, and this is where the CAM-ICU part comes in. Okay, so level of consciousness we all kind of learn as ANO times 3, right? So, but in the ICU, it's a little bit more difficult because we've got an intubated patient, and so we use these 2 scoring tools to determine consciousness. So it's arousability for the RASP and content for the CAM-ICU. That's basically what that is. You can use this also for pediatrics, but the questions are a little bit different. So this one is, will a stove float on water? And I think for pediatrics is an ant bigger than an elephant? Okay, or, so questions like that, just, so that's what that is, okay? Next. This is the pediatric one. Oh, there it is. Is an ant bigger than an elephant? Is ice cream hot? You know, things like that. So for pediatrics, in pediatrics, this is what you would be using. So, summary. One problem always leads to the next in ICU, but also on the floor, but in ICU in particular. You've got someone in pain, they're anxious, they're agitated, and then you want to sedate them, and then you sedate them, and they become delirious, and then it's just like this vicious cycle, right? So this is really nice. I kind of like this picture, I don't know why, because it just kind of shows you what ICU looks like. It also looks like the ER video. All right, so when the patient's on a mechanical ventilator, that's really our challenging patients, the mechanical ventilator patients. So, the problems with prolonged ventilation is VAP, ventilator-associated pneumonia. That is a bundle. That's another bundle, VAP, ventilator-associated pneumonia. So, VAP, immobility, you can't move because you're on the ventilator, and delirium. You get delirious because you're on the ventilator, you got a tube in you, you're anxious, you get sedated, you get delirious. And then sedation used to relieve anxiety and agitation. Sometimes we're over-sedating, sometimes we under-sedate. This is patients on ventilators. And then, either one of them would lead to some harmful outcome. So, how do we manage this? The other bundle, the ABCDE bundle, which I would say most ICUs use, including Sequoia. Now there's an ABCD, which is in the ER, which is airway, breathing, circulation, decision, okay? But the ABCDE bundle is awaking, breathing, coordination, delirium, early exercise. Okay, so that's the ABCDE bundle. So the component is awakening and breathing trial coordination. What that is we're going to try to, what we try to do is we cut down on the sedation. We actually cut it in half. And then we do a wake trial, to see if they can wake up with half the sedation. And if they can wake up with half the sedation for X amount of time, then we do a breathing trial, to see if they can breathe on their own. And the C part, coordination, is not just coordinating between the two, awakening and breathing trial, it's to see if we can choose. C is also for choosing the right sedative. Then the delirium assessment and management, and then early exercise. And I'll get to those later. Okay. So this is the spontaneous awake and breathing protocol. So basically what you're going to do is you do a safety screen to see, SAT means spontaneous awake trial, to see if they can wake up. You're going to do the screen, and if they don't pass the screen, then they fail. And then, you guys can look at that. But then after that, then you do the breathing trial. You do a breathing screen, spontaneous breathing screen, and then if they pass that, then you can start trying to wean them off. So spontaneous breathing screen, you want to make sure there's no agitation. You're going to try and take them off. This is where we're trying to take them off the ventilator. You're going to make sure that their O2 sat is greater than 88%. You want their FiO2, which is the setting on the ventilator, to be less than 50%. So, because what's normal FiO2? People. What's normal? What's room air? What's room air? 21%. Right. You want a PEEP less than 7.5, and PEEP is positive end expiratory pressure. So when your patient's on a ventilator, it's giving the breaths, right? And what the PEEP does is that it keeps the alveoli open so that there's more gas exchange. Okay? So if it's a 5 PEEP, that means it's keeping it up this much. This is alveoli, so it's keeping it up this long. And if it's sometimes a PEEP of 12, or not 12, 7, 8, 9, it depends on how long and how big you want to keep your alveoli open. So that's what PEEP is. Just remember keeping the alveoli open so there's better gas exchange. No myocardial ischemia, no vasopressor use, and inspiratory effort on their own. Okay. So that's basically the trial. And they do this, I think, every day. Every shift, the nurse has to report on rounds, because on the day shift anyway, in ICU, they have rounds, and the nurse always has to report the RASS score, the CAM ICU score, and what sedatives and analgesics the patient's receiving, so that they can start this spontaneous awakened breathing trial. Okay, then we want to assess for delirium, and what we do is we do stop, think, and maybe medicate. So this is a stop. So you want to ask yourself all these questions. Can any of the meds be lowered or stopped? Can we minimize the amount of sedation? Can we titrate? Can we change the drugs? The think part is there anything that's causing the delirium? And this is the different types of reasons you can have delirium. And you can use this for non-ventilated patients as well, this think model. And then perhaps medicate, okay? Because there's really no treatment for, pharmacological treatment for delirium.
You might have answered this question already, but just want to know. So what about being ventilated causes delirium?
It's not so much being on the ventilator, but it's all the things associated with being on the ventilator. It's the pain, it's not being able to communicate, it's anxiety, it's not being able to sleep because the ventilator is just breathing for you. It's just all those things, and then it's just really super uncomfortable to be on a ventilator. So you want to just kind of like sedate the patient.
Uncomfortable, like painful, or?
Uncomfortable, like painful. The tube is this big, okay, and it's just down your throat.
And you can't talk.
And you're not breathing normally because the ventilator is breathing for you, so you can't. The ventilators these days, they have, I mean, they can account for you just trying to breathe on your own. So maybe just real quick, there's different kinds of modes. There's assist control where the ventilator just gives you 12 breaths a minute, just 12, in and out, 12. Then there's a IMV mode, intermittent mechanical ventilation mode, where the ventilator will give you maybe 5 breaths, and then every time you do this a little bit, then the ventilator gives you a breath, okay? And then there's other modes where they try to give you, the ventilator will give you a pause. That's a physiological pause. Everybody pauses during the day, right? You kind of sit and then you go outside, okay? So the ventilator will give you the physiological pause. But if you're sleeping, right? Let's say you're sleeping and that ventilator is just like giving you breaths. It's uncomfortable. It's really uncomfortable. Plus you feel like, most patients feel like they just want to get that tube out. That's what really makes them agitated. It's just having that tube in there. Plus you probably have an NG tube to boot. That's not comfortable. So anyway, it's not so much the being intubated, it's more everything else that. Okay, so the E part is early exercise and progressive mobility. So if you're on a ventilator and you can't move, right? You've got these really cool fancy beds that inflate and deflate and everything, but you can't. If you like to sleep like this on your side, you can't do that. You're not comfortable, no matter what the nurse does, where she puts the pillow. I want to have my arms twisted because this is how I sleep. This is really how I sleep. And I want to be on my side, and I'm like in my fetal position. You can't do that, right? So imagine being on a ventilator, and you're either like this, or you're like this, or like this, right? So you can't move. So prolonged bed rest will cause muscle atrophy, right? And this is not just on mechanically ventilated patients, even people who are sick on the med-surg unit, they can't get out. Orthopedic surgery patients who have complications and they can't get out. So early exercise and mobility will actually help them get better. So the E part of this ABCDE is early exercise and mobility. So this is the early exercise and mobility protocol. So there's a screening like there was for spontaneous awaking, spontaneous breathing, and now there's a screening for mobility. And the ABCDE protocol is really bundled, it's really cool because you have every day you have the respiratory therapist, the physical therapist, the nurse and physician all meeting to see if we can get this patient off sedation, extubated, moving, and hopefully out of the ICU and not deal with delirium. So this is basically the progressive mobility protocol, okay? We start off with passive range of motion, then we go to just sitting at the edge of the bed, even on a ventilator. You can sit at the edge of the bed, even on a ventilator, to, moving around and then walking. Hopefully, when you don't walk when you're intubated. You could walk, actually, you could have a TP soon, but you guys get the picture. Okay, so finally, the last concern of critically ill patients is families. So families, how many of you have had a family member, friend, or in the ICU? And wasn't it just sucky that you couldn't get in to see them and talk to them and sit with them, right? I mean, well, now you can, but before, the ICU hours were very restrictive. We, as nurses or as healthcare providers, felt that it was better for the patients to not have family members there because the family members just got in the way. And that we felt like we just needed to do our work. And so we had very restrictive family visit hours. But really, if you think about it, you're on the other side of it, as a family member, you want to know what's going on. You want to be there. You want to hold your boyfriend's hand, your husband's hand, your mom's hand. You want to be there. And so there was a lot of research done on whether it was advantageous to have families in the ICU. And really the evidence shows that there's no downside to having families. In fact, there's no downside to having family members present when we're doing CPR, when we're resuscitating patients. We will allow a family member to be in the room while we are resuscitating patients. And in fact, let me just do this here. In fact, most family members who have witnessed the resuscitation of their family member, even if it resulted in death, said that they felt like everything was done. Okay? Because sometimes when we're resuscitating and then we go out and we tell the family, oh, we're so sorry, but he didn't make it. In your back of the mind, you're thinking, well, did they really try everything? Right? But when family members are there to witness it, and they see all that stuff that went on, they realize that you're really doing everything you possibly can. And so they actually feel better. And they say that would they be in there again? Yes, they would absolutely be in the room again. There really is no disruptions in care, with the caveat that you can't have the whole family in there, right? It's, the ICU is a very restricted environment in that you don't want the whole family in the room and having a party, right? You want either one or two people as a designated person to be in the room. And the patient actually feels better having their family member in the room. So the expected practice is all family, this is from AACN, American Association of Critical Care Nurses, all family members of all patients undergoing resuscitation and invasive procedures should be given the option to be present at the bedside. A little bit difficult as a nurse to have that family member there because, family members always asking you questions and you feel like you can't answer and you don't know what to say, but, as the family member, they understand. They really do. Question, yes.
So is this at all times or just during visiting hours?
All the time.
They're always welcome.
If they're being resuscitated.
Okay.
And again, it's a fairly new practice, and at first it wasn't, because what you do, it looks like it's total chaos, and you're doing everything. You're grabbing every drug, you're doing everything you can, but it really does. You let them stand in the back, and again, like she said, not the whole family, but it does make a difference. And at first it was hard for nurses and doctors to let the family in when you're doing this, because this is like, rough and tumble medicine. It's not as scripted. It's never scripted, really. It's you do what you can to save their life.
Yeah.
Okay, so That's it.
Yay! Wow.
Were you drinking at some time?